Thank you all for coming back after break. I'm Professor Nora Gross from here at UCL, from the Leonard Cheshire Center. And this last session today is Frontline Service Delivery. And we have 4 very interesting speakers who are going to share their knowledge and insight with you. We're first going to hear from Julia D. Ruben, who from D-Tree. She's the Zanzibar Program Manager from D-Tree. And we've asked her to start off with a talk of about 15 minutes, and then the 3 other speakers, after they've seen the slides, will come up and each give a brief presentation of about 10 minutes, and then we'll have time for discussion. So without further ado, let me turn the floor over to Julia, who's going to be talking on integrating approaches.
Thank you very much. My name is Julia Ruben. First, I want to thank you for having me, and then I want to apologize for being here because I'm kind of stepping in for our country director who couldn't quite get her visa in time. So this is sort of a last-minute thing, but I hope that I can represent her well enough. A little bit about what D-Tree does to start out with. Some of you know us and some of you don't. So our focus has been on basically taking health protocols, and these are community health protocols or facility health protocols that are often complex guidelines that are difficult to follow and expensive to print, and we turn them into electronic protocols that are easy to use, easy to change. We design them and test them. We refine them, we deploy them, and we hope that they help to improve care. And we don't do this work by ourselves. We do it always with other NGOs, always with the Ministry of Health, always supporting whatever national guidelines are already there. And we kind of focus on the broad spectrum. We try to cover what one might call the continuum, kind of adolescent health, family planning, into antenatal care, safer delivery, post-delivery. So that's kind of our dream vision, our integrated vision. But what I'm going to talk a lot about today is maternal and child health. The theme is integration. And integration can mean a lot of things. We could talk about integrating facility and community, integrating these kind of health issues that I just referred to. And I'm going to talk mostly about integrating different mHealth interventions onto one device, into one application. And then what came up earlier in the sessions was integrating that into the broader programs. Using it as a tool to improve health and reach the goals that are often already there, and not having it be a separate add-on that you look at it on its own. This is our esteemed colleagues who are not currently in the room, but kind of came up with this framework. And these are different types of kind of mHealth interventions as health strengthening tools. And I'm going to hopefully touch on several of them. I have circled or squared in red kind of the main ones that D-Tree works on, and on kind of what hopefully I'll get to through talking about 2 different programs. One is the one I've been managing in Zanzibar, which is a safer deliveries project about getting women into the facility. But first I will talk about our community case management program, which is being implemented in Malawi currently. And this project, so basically uses health surveillance assistance to deliver communication management at the very rural areas in order to improve care. So they can treat or they can refer to the larger facilities, and this is for children under 5. So what's interesting about this application is that it combines decision support, which I already described. There's a patient record there is appointment scheduling, monthly reporting, there's also a supervision application, and a commodity tracking system, and it's all in this one application that's very easy to use and runs on an Android platform. And I'm going to give you just a run through of kind of what it looks like. This is an example of just the sick child protocol. Does the child have a cough? If so, it asks you how many days. Does the child have diarrhea? If so, it will also ask you how many days. And this is its way of getting down to the kind of the danger signs. If you need to treat the child, you might need to treat the child for home treatment. If it's really dangerous, you might need to give the child the initial treatment and get the child to a health facility. And the application tells you how many tablets you should give, whether to refer or not. It tells you how many, so you can put in how many tablets you've given in this example. If you haven't given the right amount, you answer why. So you can imagine that, this can be very good for supervision and also helps with these stockout issues that have come up before. Another tool that's integrated into this, which seems really simple, is the Stopwatch, because part of the protocol, if the child has a cough, is to measure for fast breathing. And so instead of guessing or using or having to carry another device or making sure that another device is working, all you do is tap on the stopwatch as you go, and you can get an accurate count of breaths per minute. And this actually, this lack of having this device has been kind of a well-known reason for over-referral in the past, and now you can really get an accurate count of breaths, and depending on the age of the child, the application will tell you whether it's a danger sign or not. This is patient history, so you can see if the child came in before or not, how you treated them, kind of go through I'll get into the vaccinations in a minute, but all their kind of follow-up information and kind of past history, so that you are sure, if you've already treated them and it hasn't worked, etc. You can schedule follow-up appointments. It will tell you when the child was supposed to come back, and so a lot of HSAs have said this is really helpful because they actually not only know that they should have come back and didn't, but now they have a phone and they can use it just like a phone to call them. You know when vaccinations are due, when they're overdue, and you can again, it walks you through counseling the woman on getting those. In terms of supervision, this supervision has been a huge challenge in the rural areas, and so this kind of helps the supervisor walk through both a checklist, the supervision checklist, and then just even remotely, you can see, how are my HSAs performing? How many children are they seeing? Are they filling all the forms they're supposed to fill? Are they scheduling follow-up appointments, etc.? Monthly reports, again, this is widely popular because it just makes it so much easier to fill in that monthly report that they have to fill in anyway. And this is helpful for the HSA as well as the supervisor. And then we have the C-Stock integration, which is in partnership with JSI, and it's normally through an SMS, but this system, and using codes, and this just simplifies it a bit. You can just select what you're going to report on, you can put in the number, you send it in, and done. It'll even remind you when the report is due. So in a way, it's just kind of a dummy-free add-on for this application. On the back end, there's a web dashboard. So you can see here, this is, I believe it's new patients. I'm sorry, you can't really see the details very well. I'll give you one more example. And this is actually, so you can see kind of the bigger view of how many patients and how many visits, and then here, this is actually an example from our family planning application, but you can even break down what methods or what treatments have been given in a given district, for a given clinic, etc. So that is one. And I also just want to now talk about this Zanzibar project, which I know the most intimately. And basically, the goal is to reduce maternal and neonatal mortality by increasing facility delivery. And the whole conceptual framework is these 3 delays. So the decision to seek care, the transfer, and the treatment. And so we are trying an mHealth intervention to kind of help remedy all 3 of these at once. And this is a picture actually of one of our home visits. So that's a pregnant woman surrounded by children. And basically what we do with this is we register pregnant women into the phone. We get permission, which has turned out to be really important for the woman to go to the health facility from either her husband or mother-in-law or whoever the decision maker is. That's also registered on the phone. They agree on birth plans based on her risk factors. You take a medical history. If she's had a previous C-section, she's not going to plan to give birth at the local primary health care unit. Another important aspect is counseling. So on the home visits, they counsel the women. They remind them the importance of facility delivery. They remind them the danger signs they need to look for. And then they refer them as needed. And when the referral needs to happen, the application will tell them based on a danger sign. And then they can coordinate the transport, call the health facility, and importantly, escort the mother. So they pay for transport using mobile money, which they have in their accounts. They're verified on our end centrally, which I'll show you in a minute. And then they monitor mother and baby for 10 days after delivery. And in that monitoring, they're encouraging postnatal attendance as well. So the application is similar, and I'm short on time, so I'm not really going to go through it, but it will walk you through the danger signs. It will tell you if she need to be referred. It will tell you if her birth plan needs to change. Similar dashboard. And here we have kind of our financial tracking, which takes information from the application, information from the mobile money accounts, and it's all just there in front of you. So you know when they need money and you know when they're okay. And you can refill those mobile money accounts so that delay for the transport is never there. The results, so we have reached a 77% facility delivery rate. This is over 13,000 women who delivered in the last 2 years. We looked at women whose place of last delivery was home, thinking that these are really the ones whose behaviors you might be changing. So we were sure we weren't kind of pulling from the top. 66% of those gave birth in a facility. And then postnatal care, I mentioned before, is a huge problem in Zanzibar. People just don't go. And we actually reached 88%. And then again, something the ministry has really been trying to do in Tanzania, or in Zanzibar, is get people to primary health care units and unclog those higher level facilities. And that has became a secondary objective, and you can see that we actually increased that to 34% from 4%. So that is that project. Other ideas for integration. Here, you pay for performance is very hot these days. Here you can see how you could, and we are actually using this in the family planning. The ministry can look and they can see, okay, are they seeing enough patients, and they rate their pay scale based on these data. So it's on the phone, and then it's also on the dashboard on the back end. Another idea, so not only do you answer the question, but you're reminded through education that you can just press on your phone to see, you're reminded how to look for chest and drawing because maybe you forgot. And I will wrap up with lessons learned. So technology changes all the time. So we've learned that be aware of that. Don't put too much into it in the front. Make it as flexible as possible moving forward. Don't let it push the program. As in both these programs, the phone as the phone was one of the most important uses of the technology, and that's great. Like, we don't actually need more than that. If we're connecting people, if the CHW is calling the facility before the woman gets referred, it's great that the phone triggered that referral. It's great that she can pay for it during mobile money. But if she gets to the facility and there's no electricity or no staff, then that was all for a waste. And so that calling component of the intervention is essential. Data-driven supervision. The great thing about decision support is you have all these data, even if you didn't mean to. So even if it wasn't like the initial reason for the intervention. And so it's great to use it, and it's great to show your colleagues at the district how they can use it. And then, again, users feeling like the application supports them. This is not news. You don't want to add a double burden if possible, which I think is a frequent problem with mHealth. And finally, the integration. So the success of that Safer Deliveries program, which I had to talk about really in brief, we used all these different sort of mHealth interventions in one very simple device. It was just a low-level phone. But sometimes you did all that and the car's waiting outside and transport's ready and she's still not going to go because there have been rumors that there's witchcraft at the health facility or that we're Freemasons and we're going to take her away. And so you need to integrate into, and BCC has come up a lot, and BBC. And so I think like even if that's not your specialty, like D-Tree, for example, we use our partners to get that done. That's kind of not in our expertise. So I think that's really important. And that's it. Thank you very much.